Hello.
Hey, how you doing?
Is my voice clear? John, am I audible?
Yeah, I can hear you.
Okay, thank you.
Okay, let me put my camera on too. How you been, Atta?
Excellent. Fine.
Here we go. Okay. Good. Okay, and then,
John, can I just check my slides?
yeah, you want to test them?
Yes.
Sure.
As you remember, last time nobody warned me, so there were some issues.
Do you have any videos in there?
No, I have not.
Okay.
So I'm just trying to change the slides. Let me know you see the from first to second, third, fourth. Is it a smooth transition? Can you see my slides here?
Yeah,
Okay, good. So, okay, let me know when I stop sharing this.
yeah, a few minutes. About more than 5 minutes.
Okay, so should I
Yeah,
stop sharing?
get off it, please.
Okay,
So
good.
I can introduce you and they can see your beautiful face.
Sorry.
Hey, did you see that that was a great conference, man. It's still going on. They had some good names, really good names.
Yeah,
And
yeah,
Lawton was awesome. He's the best. I mean,
yes.
he's a good presenter, relaxed, knowledgeable. He draws from a lot of experience, and
Mhm.
technically, with the video and the way he has it organized, he's the best, definitely.
No, no doubt in it.
Yeah.
No doubt.
And I find out now I can see he has a paper organization called Mission Brain. Okay. They don't do anything. They don't do any televising. They go to Tanzania for a week. They go to Guadalajara, Mexico for 1 week. But that's nothing. That's basically the start. You need every weekend webinars, every weekend to developing world. So
Barrow is one of the main center in the world
Yeah, yeah. If I can just
for.
get his ear, I'm going to try to get his ear because yesterday I had a meeting
Mm,
with all of Central America, Guatemala, Honduras, Panama,
mm,
Nicaragua, Costa Rica. I had a meeting with the heads,
mhm.
and I didn't tell them about my plan, but we have another meeting on Friday. I'm going to say, hey, look, we can maybe align ourselves with Mission Brain because apparently they already have relations with Mexico with Quinones. He's a big neurosurgeon from Mayo Clinic.
Yes,
Um,
it's a very
it's just a big paper organization. Doesn't do it. Let me just quickly show you.
yeah. I
Well, I'll show you later, okay? Because it's
yeah.
important. It's where
Yes.
I'm going to spend my efforts in the next couple of weeks and try to
Uh,
get an audience with him.
I have many things to comment on, share. Just let me finish this, and whenever you have time, we can meet.
Yeah, yeah, yeah. Okay,
Mm.
yeah. You want to? Yeah, I'll listen to it. Changing the time. Yeah, sure. I'll listen to it.
We will do that. We will do that. But today I see many people coming, so it's a good thing.
Well, whenever a neurosurgeon advises me on the Zoom, I say, okay, let me do the next brain operation.
Mhm.
It's
Yeah.
supposed to be funny out there. You're not laughing.
Yeah.
No, it's yeah, but time yeah is important. So, and we could always. Hello, Harshad. How you doing?
Hi, John. I'm fine. How are you?
Good, good. So
Professor.
I'm gonna introduce the show, then introduce you, and you introduce Ada. Okay.
Okay.
Hi,
Okay.
Professor Harshad.
Hi,
Yeah.
hi, Dr.
Great.
Bhatti. How are you?
Great. Great to see you.
Great to see you too.
Yeah. It's
He's
the best start of my session to see John
Yes,
and you both.
well, he's the most one of the most loyal followers. He's been following us for years, right, Harshad? For
yes,
years,
I am a great
long
learner.
time, long time, four or
Yes,
5 years, I think.
more than that.
More than that?
Yeah, before COVID.
Yeah, yeah. When we had Hangouts, yeah, remember using Hangouts? That's a little more difficult than Zoom
So
to use.
Halim is
Okay, go
Halim is
ahead.
also in panel. Halimur Rashid.
Hold on, soon.
Yes. Our neurohealthcare director Halim Ahmad is also there. So can we just add him on panel and give him uh, rights to add people if it's okay with you, John?
What's that? Someone has a hand raised.
Halim.
Oh, that's you? Okay. What you want to say? We're going to start in a minute.
So can we add Halim on panelist so he can add anybody from
No,
neurohealthcare for
no,
LMIC?
no, can't do that. They took that option away. They used to have a co-host, but Zoom took it away one day. I don't know why, because it makes it more convenient for me. It makes it harder.
Order for what?
Okay, you ready to start? Ready, Ata?
Yeah, I'm okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have another dual neurosurgery channel meeting with Ata Bhatti, and we're graced with the presence of Harshad Parekh. He's a neurosurgeon from Mumbai, and he'll be introducing Ata. Welcome, Harshad. Oh, I hope he didn't fall off. Are you there, Harshad?
Yes, John, I'm here.
Go ahead.
Yes, good morning, good evening, good afternoon, wherever we are. In India, it is good evening. It's almost 8 o'clock. And I'm sure John is enjoying mornings in the Miami. Yeah. So it's my great pleasure to be part of this webinar where Professor Bhatti is going to speak to us, who is a pioneer in endovascular as well as in neurosurgery. In looking forward to learn from him about the posterior fossa AVMs and its vascularity and how to treat and manage. Yes, Dr. Bhatti, please go ahead and explain us. Thank you. It's
Can
all
you see?
yours.
Sure. Let me just share my screen first. Welcome everyone, and let me just okay.
Okay.
Can you see my screen
Yeah,
now?
yeah. Put it on presentation mode, please.
Okay, sure.
Okay, perfect.
Okay. Good afternoon, good evening, good morning, everyone. Thank you, John, and thank you, Professor Harshad, for the introduction. I have chosen the topic of arterial feeders in posterior fossa AVMs. Um, uh, I can see that we cannot cover each and every aspect. We'll go for the basic. As a neurovascular practitioners, we have a lot of responsibility. If we remember from 2013, when the Aruba trial came and published in high impact journal of Lancet, that made the thing very uh, challenging for everyone in neurovascular specialty, because that was not the ideal study, but it was uh, meant to assess the time to first stroke or death and compared between the conservative versus those the treated cases of AVMs. And any MRS 2 or more than 2 at 30th 30th month was compared in two cohorts, medical versus intervention, and the conclusion was that the medical group had less complications than the intervention, 15.1 versus 46.2%. So having all the flaws present in that study, uh, we can take that in another session, but that was not something very individual to the cases. Yes, AVM is a difficult disease. Yes, uh, the posterior fossa AVMs are most difficult. So we try to make principles complex on the individual case basis to understand more. Now it's responsibility of us to understand, and this is a very basic talk addressing addressing few basic philosophies concepts to understand this posterior fossa AVM amongst the most difficult part of the AVMs. So I would like to acknowledge that many of my concepts are being and slides and material are being taken from different authors. I would like to mention Professor Yashir Gill, Valavani's Professor Lawton, his seven aneurysm, and many more authors. So this slide is showing the embryology of the arteries of the brain lecture presented by Moffat. And he, as a part of the keynote speaker, mentioned a unique case back in 1960s and referred the importance of understanding embryological development. So he has talked about a case with the left internal carotid artery region, uh, um, origin of posterior circulation, and large branch of ICA went through the hypoglossal canal to supply the basilar posterior circulation. And he mentioned it as a cadaveric presentation of the fatal complication of uh, vascular vascular problem in that particular autopsy patient. And uh, he mentioned that he looked into the literature and found very few things regarding the understanding of different variations and things, which are very important when we look into uh, the topic of vascular malformation, or going beyond that, posterior fossa malformations. So he mentioned 1948 Paget's work, which I mean, situation is like from 40s to 60s and 60s to late 90s. There were most neglected attention from all the many of the players in the neurovascular field. But now there is a renaissance of uh, neurovascular specialty as a vibrant, and people are taking interest into historical significance of these things. So continuation of that, we can see that the neurovascular development is a complex process of angioblastic artery, venous, and capillary formation, penetration of perforators, and different sort of uh, characteristics of vascular structures joining together, regression, annexations, and flow reversals. And this is remarkably done in a child, in a growing fetus. And by the stage of 50 days, at 40 mm, embryo fetal circulation is similar to defined adult configuration. You can see the posterior circulation with this arrow has a direction um, towards the AICA, till AICA of the posterior circulation at the 50 days age and the seventh stage. And it's a vibrant process in a growing fetus. And you can see the AICA, you can see the PICA and superior cerebellar artery, uh, which is being supplied by the anterograde flow from the ICA. Uh, and you see many connections regressed, which are being present in the anterior and posterior circulation system in the growing fetus. So that sort of initial concept development and having a dynamic knowledge of that growing fetus, as well as having the probability of different problems at that growing vascular tree, um, the detailed, in-depth history and detailed review of neurovascular development gives a very good basic foundation of understanding of different normalities and abnormalities. And obviously, the growing fetus, if facing through different genetic or syndromic problems, makes those growing vascular tree vulnerable for many problems. So the game changer was Moniz, a clinical neurologist who in 1927 in CNS French Society, Paris, presented his work of cerebral angiographic patients that was called by him as a lencephalography arterial, and that gave uh, that gave dynamic visibility to the cerebral vasculature, and later on the development in the form of digital subtraction, road mapping, 3D rotation, cone beam CT, 6D rotational angiograms. Quite recently is the talk and cone beam CT with its superiority of going into more details of the tiny vessels, and in here AVM feeders, nidus, and venous sites. So microcatheter based work done by Valavanis, my mentor, um, was a major groundbreaking development further into understanding of more precise analysis, and it was very helpful, especially for AVM, to see the type of defined feeding arteries, their patterns, numbers, vascular connections and details of nidal compartments, uh, the types of AV shunts, and also it also was essentially giving perfect information regarding the secondary induced phenomena in those disease processes. For example, the conversion of uh, perinidal angiogenesis, conversion of different shunts, and those details which could not be possible to see on the conventional angiograms. So this was published in 2005, but the work started in late 70s and early 80s. So as you see, there are three components of any AVM: the feeding arteries, the arterial site, the nidus, and the venous drainage. And for making us qualify to treat those, we have to be very precise and clear about angioarchitecture. The different subsegments are what we call as compartmentalizations, the variations in different pattern of supply, nidus, the venous drainage, uh, different flow dynamics, and different serial changes in those to make us eligible to pick which AVM is more high risk and which one is the less high risk. Obviously, the multidisciplinary approach is something which we always emphasize on. So finish the data by the grand name and the master in the field of neurovascular, Hannes Niemi, um, microneurosurgeon from Finland, has described his experience of AVM, and this series had a very long track, 1942 to 2005 patients, um, uh, with 238 number and mean follow-up of 13.5 years. So the chunk of posterior fossas were very less than the supratentorial AVMs. It was 10 to 15%, but the annual rupture of risk was very high, 11.6% compared to 1.3 to 3% per year described elsewhere in the supratentorial part. So this is something making this um, particular location very, very high risk. Um, and we have to see that still a lot of new diagnostic clarity is being tried to see the more dynamic changes of arterial feeders, nidus, and venous informations. And here, the recent Shapiro has described, Eaton and Shapiro described this six-dimensional reconstruction by taking two different 3D rotation images of both sides of the ICS to describe that clarity of nidus, the intranidal aneurysms or abnormalities, the shunts, high flow shunts, and that is the dynamic which is present in the Siemens made DSA machines, but the software were not being utilized in the way now the neuroendovascular specialists are using it. This is also possible to do a selective blockage by the microcatheter balloon technology to see the different combinations and different dynamic changes on the selective control of circulation from the different aspects. So the main concept here is to go and see the details. So the dilemma is the basic nidus, what we call nidus, is still uh, sometimes becomes a gray area from the perspective of normal and abnormal. So it's very important to have a very precise definition of that nidus, and for that we need to have a uh, more clarity in our concepts, images, and image interpretations. So, Yarkes et al. Describes this AVM angioarchitectural details, giving that from type 1 to type 4 based on the simple direct fistula or multiple feeders in a nidus here draining into single uh, primary venous system. We can see a lot of more complex things with multiple arterioles and enlarged venous sides. We can see multiple compartments within the nidus, and the veins also has different primary veins leading to the predominantly principal vein of the drainage of that system. The complexity increases with the type, and that describes a very demanding pre-operative planning of those feeders. So Professor Lawton, in his 7 AVMs book, described the different type of large variety of various AVMs, putting them into 7 categories and describing and organizing them into a more conceptual way, giving us a concept of a box which is very useful for microsurgeons, having the 6 walls, giving attention to the arterial feeder sites, giving the respect to the venous side, and um, emphasizing on the microsurgical techniques. So we today will talk about the posterior circulation feeders, which sometimes involves the ventricular system, and we also see the posterior inferior cerebellar artery is mainly involved in many of these vascular lesions. So there are 2 broad categories which are very important to understand. One is the brainstem AVMs in the posterior fossa, which are luckily very rare, um, but amongst the 10 to 15% of total intracranial AVMs, 75% percent of the AVMs are in the cerebellar hemispheric region with or without involvement of the ventricles. So we can see it further classified into cerebellar, the brainstem, and there are feeders from the posterior circulation giving some contributions to the intraventricular and the temporal regions. So here we see the cerebellar PICA based supply, the complex diffuse nidus with 2 principal draining veins. So from the perspective of microneurosurgeon, uh, it's very important to uh, have superficial or deep based, the compact or diffuse nidus, but from the perspective of more selective approach uh, and hunting of the nidus and the feeders, we see that even that nidus uh, has many challenges because there are many chambers and compartments having their own veins. Sometimes they communicate with the each other. Other times they don't communicate with each other. So during the angiographic evaluation, one has to go into detail of each and every aspect, not only in the nidus, but also in the environment surrounding that AVM. The target should be defined very precisely. So any successful procedure needs a very meticulous targeted planning, and if the target is defined well, so you can predict the outcome in a very confident way. Obviously, the learning is an art, and you have to learn from each and every case in a different way. And it's here we see a lot of gray areas, like who will treat it. The mode of treatments are multiple now. The microsurgery has been supplemented by the endovascular arm, and the radiosurgery is also one of the modality involved in the AVM treatments. Not only that, but when to utilize which is a later stage, and there is a, a pressing need that uh, unbiased multi-speciality uh, uh, process which can give attention to every patient in a unique way for their own problems, and to find out the challenges in the local system, and offer them the best available solution to the problems. This is what we call as the workflow, dependent on the local experience, the local uh, available expertise, and perhaps the data and their own results. But the emphasis is understanding the target, and the posterior fossa, as we mentioned, that it's a unforgiving place, and where when we see the posterior fossa AVMs, they are highly vulnerable for intra for the ruptures, and many times in the cases in the real world, we see the ruptured hemorrhagic uh, AVM in the posterior fossa as the first presentation. Besides that, there are other uh, other mode of presentations which are maybe incidental for any non-specific symptoms. But what we see more common is the hemorrhage, and these hemorrhages are very alarming and overwhelming for the system. So as we know that this posterior fossa has the three main vessels. The both the two vertebral arteries in different configuration, depending on individual case, have PICA, sometimes PICA-AICA complex together, the superior cerebellar artery, anterior inferior cerebellar artery, and posterior cerebral artery in the form of the main involved in the disease process. So it's also important to further divide based on the anatomical location of these AVMs. For example, Professor Lawton has described it in further categories based on the anatomical presentation. The suboccipital, vermian, the midline vermian, petrosal, tonsillar, and tentorial. So these are the cerebellar AVMs, and in the brainstem AVMs, you have different sort of presentation. It can be the midbrain and pontine. And brainstem AVMs can be differentiated by their location, um, as I mentioned, midbrain, pons, and medulla, and they have some propensity in the vicinity of fifth cranial nerve. So, to give you the um, the review of the nidus and draining veins based on the Spetzler Martin gradings. So there is the eloquent and non-eloquent brain regions highlighted, and brainstem, the feeding arteries having a different sort of supply. Some of them have no involvement in the disease process. What we call, what Professor Lawton called it as a bystander vessels. We see the sulci having the descending sulci, ascending sulci. So it depends where we are seeing which is the primary supply, which is the secondary supply, the perforator involvement, and the deep small perforators in the form of choroidal involvements. So the draining vein pattern is also based on the nidal complexities. You see many nidal components, the tortuosities, sometimes nidal or prenidal aneurysms become a challenging factor, and some studies have described that more than 50% cases of AVM with the PICA feeders, the PICA aneurysm prenidal presence and rupture is the main reason, and there is a controversy which to treat, and the consensus is they both have hemodynamical association. So the endovascular arm provides a very good answer to that fragile element of the AVMs can be treated even in the subrectal hemorrhage cases. And there are controversies on the timing. There are controversies on the mode of treatment depending on the center to center and available expertise. So similarly, the nidus also has some borderline areas where you see the arterial, feeder arterial impasse. They are the transit distal feeders with some supply to the normal brain. So they are the one which can cause many postoperative problems when we treat it by suboptimal understanding of these transit vessels. So these Ampasa vessels are very important to recognize, and the micro super selective microcatheterization give us a chance to understand different components. And you see that there can be multiple feeders, there can be PL feeders uh, coming from the ECA branches. So now this initial introduction of the cerebellar brainstem and the generalized concepts of the AVM nidus feeding of vessels, the draining veins. We switch to the perforators and important perforators in the posterior circulation. We see that these perforators are abundant, and they are arising from sometimes from vertebral, pica, the basilar perforators. So you see a lot of perforators from the basilar trunk. There are also many perforators from the P1 segment of the posterior cerebral artery at the termination. The superior cerebellar also communicates with the anterior cerebellar, anterior inferior cerebellar, and posterior inferior cerebellar. So here we see the brainstem from the posterior. So we see that the left AICA pica has a combined complex, and the right AICA is separate than the left. Um, the right AICA is separate, and the right right side of the PICA is separate, but on the left side you see the both PICA-AICA complex and left medial perforate uh, perforators also seen here. Different pontine perforators are seen here, which are long and short, and they can have intermediate communication channels. So in the same way, we also see the lateral paget arcade, which is the perforators arising from the terminal vertebral and pica region. So at the terminal end, we see perforators, sometimes the single perforators. So it's very important to identify these perforators, and this basilar bifurcation area, we sometimes have a major stem of uh, perforator in the form of what we call percheron, artery of percheron, and that gives the whole supply to the perforator deep diencephalic region. So this makes the sanctity of this vessel even higher, and this codominance impact on the disease and intervention course. Similarly, we see in the selective catheterization, we can see the midbrain perforators, and it's very important to understand the course, the numbers, where they are supplying, and how they run in the paramedian or medial surfaces to understand the nidus. So here we see the importance of variations. So normally the C6 transverse foramen has the vertebral artery force in the cervical region, and it can vary from patients to patients. And here we see the angiogram showing the vertebral artery and the dominant vertebral artery on one side. Here we see the PICA, and the basilar stem is not visible in this, but the PICA territory has a different loops, and which also are important, because the PICA is one of the very important vessel, and anatomically it has an anterior medullary, lateral medullary, the um, the higher vertical part, and then the tonsillar part. They all have a different significance and in the course. And what we see in the lower images is the origin of the anterior inferior cerebellar artery, uh, the PICA, and also the superior cerebellar artery, which has more variations present. And the important most thing is in the PICA course is the choroidal point. Here you see the choroidal point. The importance of choroidal point, you see the second higher loop. By the time the PICA goes posterior laterally, crossing to the posterior medullary region, uh, uh, going into the choroidal point, that choroidal point defines the safety zone. Any microcatheter based or microsurgical intervention beyond the choroidal point carries no risk for the brainstem. So this choroidal point or the safety point is the concept which helps the endovascular strategies while injecting the glue or onyx, or a micro neurosurgeon taking down the vessels or the feeders during the dissection phase. So generally, the scope of today's talk is not for what to treat in which way, but just to give the anatomical basics of posterior fossa AVMs. So here we see the variations. Sometimes the pica arises proximally from the vertebral and from the distal. Distal, you see the similar basilar bifurcation. So if the pica is too proximal, then the brainstem perforators are being supplied either by the uh, basilar, proximal basilar, or the vertebral itself. So at times we see the extradural pica, which has nothing to do with the brainstem supply, and in that case the vertebral gives the most important branches, like you see the anterior spinal artery arising from the V4 segment, and in the similar way there are the communications between the territorial AICA, PICA, and the superior cerebellar artery at the hemispheric region of the cerebellum. So that is why the cerebellar bleeds has less mortalities compared to the brainstem. So we cannot undermine the importance of external carotid branches and the importance of six vessel digital subtraction angiograms. In these pictures on my left, I can show you the ascending pharyngeal arteries in the neuromeningeal trunk and occipital artery and the different branches, mestoid branches, and the muscular branches and the dural branches arising from the occipital artery and also the neuromeningeal trunk. So these branches can supply along with the anterior external carotid branches from the middle meningeal, the petrobasal, the different cranial nerves, for example, 7, 9, 10, 11, and cranial nerve 12. Uh, they they um, they can be they can cause many neurological issues if there is a proximal injection of any glue or onyx or any material. So here is the cadaveric specimen showing the vertebral, and we see the tiny perforator vessels, the double superior cerebellar artery, and the asymmetrical basilar bifurcation. So it's very important to know each and every vessel, to their course, their safety zone, the relationship with the surrounding cranial nerves, uh, to uh, to uh, to speculate about the flow dynamics. It's very important to have identification of PCOM artery, um, if it's giving support to the posterior circulation. In the case here, you don't see a dominant posterior cerebellar artery not filling from the vertebral, uh, and we see here the circle of Willis showing no PCOM artery on the MRA. So these tiny small vessels, like here we see the PICA AICA complex having some extra subarachnoid hemorrhage blushes. So we also see uh, some uh, some some arrows defining the different parts of the vertebral base post vertebrobasilar circulation. So these are the normal variants. So similarly, as we mentioned, this is the vertebrobasilar system, and the PICA has a anterior medullary, posterior medullary, the distal branches. So the perforators from the lateral view of the DSA would look like this in the P1 area, you have a bunch of perforators. You see the medial and lateral posterior choroidal joining the anterior choroidal system, and also the different parts of the posterior cerebellar artery divided into P1 to P4 depending on its course in the perimesencephalic, interpedunculaire, or the posterior quadrigeminal systems. So the vascularity vary from different individuals in different situations. The medulla, pons, midbrain, and cerebellum um, has a supply from the vertebral artery and the different branches associated, um, shown in the colored scheme. So now, going to some um, ex examples. This is an AVM in a young patient who presented after a ventricle bleed, intraventricular bleed, and on lateral vertebral angiogram, there is a very dilated posterior medial choroidal artery supplying the AVM nidus with some um, venous venous channels here. So this the intraventricular hemorrhage extent is depending is diffuse. You can see third ventricle, lateral ventricle involved. So in this um, super selective catheter based study, you see the more details compared to the uh, conventional DSA run on the vertebral side. The selective study showing the nidus of the AVM and the more clarity of the venous system. And you see that there is arrow which is showing the internal cerebral vein going into the vein of Galen and then transverse sinus. The speed of the flow on catheter superselective injection gives you a very good idea that what diluted amount of glue or onyx is required, what pressure is required, and these sort of informations. So here the nidus is small, um, and this microcatheter is taking care of the full picture of the nidus, and this is small, and the glue-based injection. Here you see the microcatheter tip, and you see there is a rule that whatever you see in terms of nidus should cost when you put a glue. So that should tally with what you saw during the nidus injection. So although the size is important in AVM, but it's not the only size. Very small occipital medial AVM in this hemorrhagic case, being the supply feeder is from, you see the posterior cerebral artery. This is the P1 before the PCOM region, then P2, P3, and this is arising from the P4 region. And you see the nidus is being supplied. Here is a small tiny nidus, and the microcatheter tip based glue, acrylic glue, the target is very small, so that has to be packed with the glue or onyx or anything. So you can only do it if you are very clear about the nidus size. Otherwise, the surrounding normal vessels are at stake. So the control angiogram in this same case is showing no more residual. You see no more nidus, no more venous appearance on the arterial injection, and uh, this is how you approach to the main feeder. you make sure that that is the principal supply to the nidus, and the glue uh, has to be penetrated into the venous site to get a cure. So only blocking the proximal artery will lead to the rebound recruitment from the other sources and will make the natural history worse. So the key word is super selectivity, the very precise approach, and in this case, this is the second one, which is showing a very diffuse nidus, and this diffuse character has a supply from the PICA, from the AICA, from the, these are the three main supplies. You see the nidus here, another nidus here, and there are many contrast enhancing lobular changes within the nidus. So these two niduses are there, and within the niduses there are the weaker spots, what we call as the aneurysms. Intranidal or perinidal angiogenesis is another factor which is resultant of the hypoxic phenomena. So in the initial slides, I showed the Professor Valavani's description of what is necessary when we hunt for for an AVM, not only defining nidus and veins and arterial feeders, but also it's very important to have a very um, uh, global look into the normal environment surrounding to the nidus. So sometimes there is a ischemia to the vicinity of nidus due to the hypoxia leads to angiogenic process which we call as perinidal angiogenesis, and it is important not to consider those perinidal angiogenesis vessels as a nidus vessels. So in that case, any intervention involving the perinidal angiogenesis, considering it as a part of AVM, will lead to the problems and uh, new neurological issues. So in the next, I am showing another posterior fossa, and this is where we see the cerebellar AVM in the territory of distal pica, and we see uh, proximal nidal aneurysm. The pica has, in one study, it's being shown that 50% of the blood posterior fossa, according to that study, had some sort of pica aneurysms proximal to the nidus. So in that cases, this taking care of hemorrhage um, needs addressing the aneurysm first, and many reports suggested that taking care in the acute phase of that ruptured aneurysms has no data supporting more AVM ruptures, and in the emergency situation you can just take care of that symptomatic aneurysm first, and then AVM once the acute phase is resolved. So the timing is also important, and understanding that the nidal element here on the right side, you see the coils taking care of that. And this patient was reportedly, despite this treatment, the outcome was fatality. And once this pica aneurysm was treated, and the cerebellar AVM was planned, in between there was another massive hemorrhage, and patient lost the life. So this is another important call when to operate in a ruptured aneurysm case. So you have to consider each and every cases on the basis of individual presentation, individual anatomy, and individual nidus characteristics. and AVMs, along with the secondary changes like the aneurysms in the nidus, what we call as the hemodynamical aneurysms, or that there are accompanied second nidus, and those sort of situations should be considered individually while undertaking the treatment. And here this slide is showing the choroidal point of the PICA. Any intervention beyond that would not affect the brainstem, because the um, safety zone for the perforators, and here you see the medullary perforators are proximal to this choroidal safety points. So one thing is very important, that the anatomy is normal anatomy knowledge is fundamental to understand the any AVM, and having the uh, hemodynamical flow concepts are important. The takeaway message is super selective and thorough preoperative imaging of posterior fossa uh, pathologies. Uh, in terms of treatment options, there are many specialties involved. So taking a multidisciplinary approach, the neuro ICU critical care, the initial support is important for endovascular or microvascular. There can be the supplemental treatment strategies. In selective cases, there is a role of radiation surgery as well, radiosurgery as well. There are many ways while dealing the endovascular arm. You have options of going into transarterial route, or recently the Professor Shepo from the EASN has emphasized the excellent role of transvenous approach, and this still carries complexities, and it needs a lot of experience to handle those, but transvenous, transarterial, or combined approaches can give you more diagnostics capabilities to understand and to define the target. So there are many high risk features. For example, having a perforator supply of the AVM. Let me just take you to some AVM. So having a lenticular, having a perforator supply, multiple tiny feeders, diffuse nidus, deep location, um, residual or previous bleed, uh, arterial feeders in the form of en passant vessels, large size. These all are the risk factors. So we are always eager to expand our expertise, uh, getting the better imaging modalities in our practice, getting more catheter and microsurgical skills is the key, but anatomy is the basic thing. The pathology is exaggerated anatomical expressions of disease, and there are many issues. While there are many issues, questions, dilemmas, when to treat, what to treat, but one thing is for sure, that posterior fossa is uniquely more complex amongst the intracranial AVMs, and they have more high mortality and morbidity, and but the natural history proposed that not treating the high risk situation is not an option, because these AVMs do bleed, they do rapidly change their flow dynamics, leading to more new changes, and just multidisciplinary approach is the keyword. I stop here and invite you for any comments, questions, so we can discuss. Thank you so much for listening.
Very good. Harshad, are you there?
Yeah, I'm there.
Okay.
Excellent presentation, Dr. Bhatti, and you've given a basic dynamics of the neurovascular uh, architecture of the posterior fossa. I agree with you. It is very difficult to treat, and they have got a lot of complexity in posterior fossa. And when they bleed, they cause disasters. And all the aneurysms, what I have learned over the period in the nidus or around nidus are flow related. And what most of the time is that even if you uh, treat the AVM, the aneurysm may get obliterated over a period of time. And with the super selective angiography and with the availability of material like onyx, it is going to give us a cure in AVM and may not require any further modality of treatment. And of course, these are all in grade 1 or grade 2 or 3A of Spätzler grade 3, where one can, easily go for a surgery, and the rest is all endovascular. It is very nicely demonstrated, and the detailed architecture, anatomy, and pathology both you have shown, and very, very learning.
I can tell you that when you go into more details, you come up with more questions.
Yeah,
So even with expanding endovascular modality, I don't think the complexities are changed. So there are new and new techniques are coming to deal with the problems, like sometimes the reflux of onyx or glue. The solutions are also coming with the complication management or learning strategies, like detachable microcatheters in the name of Apollo. New microsurgical skills are also there to tackle more complex areas now. So the main important thing, the main important message is that identification of complexities, systems, suboptimal support, the identification of potential dangers, and proper planning needs a very meticulous multidisciplinary approach, and everyday improvement in the knowledge of anatomy and knowledge of dexterity through skills is something which can make some more successful prospects for the patients.
I had a privilege to be meeting Professor Valavanis when I went to Yasagil to learn in 1990 when I joined for a microvascular. And we used to have a combined meeting, neurosurgeons and neuroradiologists. And that time when Professor Valavanis was giving all these things, and Yasargil will say, Professor, okay, this is your case, you handle this. This is not surgically. Means at that time he was so, despite of knowing so much of uh, anatomy, physiology, everything, that man will say to Valavanis, okay, now you do this because this is, you can handle this. And we used to see this in the meetings, and Professor Valavanis has really, really developed a lot into this. And one thing I heard in talking saying, don't use too many hardwares. Don't use too many hardwares. It will create more problems when you are doing endovascular treatment.
Exactly.
Yeah, he was a super giant. There is no question about in endovascular treatment. I had a privilege to be there in his department in 1990.
Yes, absolutely. His publications with the Yashagil um, in 80s, and the small book in the form of angioarchitecture of AVM, his experience of more than 1,000 AVM cases were remarkable, and nobody would argue on his result. And his AVM series had morbidity of 1.2% and mortality of 1.2%. So altogether 2.4% problems. So which
Okay,
was
wonderful.
and exclusive endovascular used in his era after Professor Yashigil was successfully treated. Uh, most of them were high grade staged therapies, and his results were 40.2% exclusively treated by endovascular at the time when
Correct.
all of the AVM experience was 10.2% as a exclusive therapy modality. But the way I mean that was decades of effort, standing in the dissection in the operating room like a neurosurgical trainee, and then gradually working on those. So still, the numbers of AVM complications are challenging for any good, any experienced, any seasoned clinician. So it's one of the prime most complex area.
I agree with you. I agree with you. And posterior fossa is one has to be very selective in whether to go for a surgical or an endovascular treatment or a combined treatment. And in that time, Onyx was not available. That Onyx came much later, and that time he was still giving a wonderful results. I know
And
Onyx gives a better results than any other glues which we are using.
Zurich philosophy was uh, based on an experience, also was based on the glue and BCA as a exclusive
And
agent used.
NBC.
And microcatheters were not that soft and that
Yes,
tiny. There
yes.
was no detachable tip catheters available at
Yeah.
that time. So I remember there used to be a pin drop silence at the time of injection, and it was a very quick um, extraction of
Removal.
catheter, because yes, removal of
Yeah,
catheter.
otherwise it will stick.
And before that, there was I mean the NBCA if stuck, which there are various reports describing those stuck catheters, can or while pulling the stuck, partially stuck, can lead to dissection and complications. So
Yes, correct, correct.
philosophy is, if you don't understand AVM, for us it was the last thing you consider as a clinician to intervene. So either to left the natural history on its own, or do the exclusive comprehensive um, uh, plan for patient and best chance, rather than just making a half-hearted intervention to make natural history worse. And in those cases, obviously the fatalities and morbidities are much more.
Mm.
And but now there are many centers, there are many experts um, using Onyx, making new techniques, using the challenging cases in a better multidisciplinary way. There are many concepts of AVM treatment, like the targeted targeted treatment, partial treatment, partially targeted treatment, depending on the high risk factors visible on the particular AVM. Like if you see um, a new onset change in the nidus, a new aneurysm, so you would prefer to go early and to take out that targeted. That won't make the risk high, if you understood that well.
No, no,
Is
I
there?
agree with you, 100%.
Thank you.
Very nice, very nice. Thank you.
Okay,
Is
very
there?
good. Very good. Anybody in the panel have any comments or questions they would like to ask? Okay, I guess a quiet. Okay, Ata, thank you very much for dedicating your time to education in the area of dual neurosurgery. We hope to become regular with this webcast to further develop the community. And of course, thank you, Harshad, one of our finest,
Thank you.
Thank you.
finest
Thank you,
pupils.
sir.
And we hope to see you, everyone, and thanks for the panelists for all coming. And we'll see you
Thank you.
probably in a week.
Yes. Bye bye.
Take care. Take care.
Okay,